We're very excited to have all of you here today to join us for a virtual town hall on South Asian cardiovascular health. This is a joint town hall presented by the South Asian Public Health Association, as well as the OurHealth study team. As you're coming in, please make sure that you're muting yourself. If you have any questions that come up throughout the event, please put them into the chat box. Our moderator, Thoin, will be addressing all of them towards the end once the panelists finish their presentations. So for those of you who have probably not heard about us before, we are the South Asian Public Health Association, which is a nonprofit that's on a national level and volunteer run. And we are the leading voice on public health issues that impact South Asians in the US. Since its inception in 1999, SAFA has dedicated itself to promoting health equity and well-being of our broad and diverse South Asian American communities through partnerships, research, education, communication, and advocacy. We aim to address the challenges that are facing South Asians and advance opportunities for people to reach their utmost potential health. In short, our primary goals include connecting people, ideas, and resources to advance the health of South Asian Americans. I wanted to introduce our board of directors. Some of them are on this call today. We have an executive committee as well as 5 different committees. So SAFA is made up of the communications committee, the research committee, development sustainability, event planning, professional development, and advocacy. And so if you have been following us on social media throughout the year, you'll be seeing various things that we put on social media in our newsletters, podcasts, and it's really, these wonderful people behind it that are doing all of that work. We've also expanded our organization to include committee members. And so we'll talk a little bit more about that later on. Just some recent achievements for SAFA for those of you who are new and have not heard of our organization, or maybe those of you who've been following along in the periphery. We are celebrating 25 years of SAFA this year. The organization was incepted back in 1999 by a group of people who were really invested in the cause of South Asian health. And so one of the primary goals this year is to really elevate the voices of those who were integral to the building up of SAFA. And so we're doing that by launching a podcast series. We've already released 2 episodes so far. Our first episode was with Dr. Ushma Upadhyay, who is the founder of SAFA, or one of the founders. And then the second episode that we released last month was with Dr. Umair Shah, who is the current Secretary of Health for the state of Washington and also a previous SAFA president. We have many more coming up. Once a month, we release them. Our next one is going to be released in March, featuring Dr. Arnav Mukherjee from Cal State East Bay, who has been an integral part of SAFA over the past many years. We've also been releasing monthly newsletters. We are now in our 3rd year of having them go out consistently every month. So if you haven't subscribed already, please make sure you do. We'll include links of how to subscribe at the end of the meeting. More recently, SAFA has also taken on climate health as an area of focus. So a few of our members have joined the Cambridge Health Alliance, or the Center for Health Equity Climate Health Organizing Fellows program, which is a year-long program. And we are coming together monthly to talk about ways that we can address climate health in the South Asian American population. One of our long-term goals is to really start a climate health task force or a climate health movement. And so again, if you are interested in participating in something like that, make sure you stay in touch and follow us on social media for any updates. Our research team has also been working really hard over the past year to put out a health disparities report. And so that has been completed, and it really takes a look at the different ways that South Asians are affected in the US in terms of their health disparities. And so we are planning to publish that soon. And so within the next quarter or so, you will be getting an email with that report as well. In addition, the research committee is focusing on putting together a research repository of all things related to South Asian research. And so if you know of a South Asian researcher or any publications that have been put out, make sure you connect with our research committee. Essentially, this is going to be a massive PubMed-like repository focused specifically on South Asian health, so that you can go onto our website and look at different topics, and it'll connect you to the different researchers, different articles that are out there based off of the topic. And so that is a year-long project that we're working on, and we hope to have that ready to launch by the end of this year. In addition, we are putting together a Caring for South Asian Patient Guide. This is going to be a coalition of essentially all the material that has been published at the moment by providers, by researchers that talk about South Asian health and recommendations. And it's going to collate all of that as a instructional guide that we would then share with practitioners as they are, especially those who work with the South Asian population, to keep these recommendations in mind as they see their patients. I would now like to introduce Doin Begum, who is the moderator for our session today. She is an environmental health sciences researcher in Pennsylvania, and then she's also on the SAFA board as our communications co-chair. So Doin, I'll hand it over to you.
Thank you very much, Amira, for the very warm welcome and introduction. So good evening, everyone. Thank you for joining us today for this important town hall on cardiovascular health in the South Asian community. Before we delve into our discussion, I'd like to address some housekeeping matters. Please keep your cameras on if possible to enhance engagement. Additionally, kindly keep your microphones muted throughout the session to ensure clarity during presentations. If you have any questions, feel free to type them in the chat and we'll address them during the Q&A session at the end. The purpose of today's town hall is to shed light on the disparities in cardiovascular health faced by South Asians and to introduce you to the OurHealth study, which aims to uncover genetic factors contributing to the heightened risk of heart disease and diabetes among South Asians. So without further ado, let's welcome our distinguished guests and speakers for today. First, we have Dr. Namrata Sengupta, an Associate Director for Science Engagement Policy and Advocacy at the Broad Institute of MIT and Harvard. Dr. Sengupta is a passionate advocate for STEM careers and science communication, and her expertise will provide invaluable insights into the importance of genetic research in addressing cardiovascular risk among South Asians. Next, we have Dr. Romit Bhattacharya, a cardiologist at Massachusetts General Hospital and the medical director for the OurHealth study. Dr. Bhattacharya's expertise lies in comprehensive cardiometabolic risk profiling. He will share with us the innovative approaches that are being taken to understand and mitigate cardiovascular risk in the South Asian population. And last but not least, we have Dr. Anirudh Patel, a cardiologist at Massachusetts General Hospital, whose research focuses on multimodal cardiovascular risk prediction. Dr. Patel's work encompasses integrating genetic biomarkers and race ethnicity into disease prediction, with a particular emphasis on understanding cardiovascular risk among South Asians. Dr. Bhattacharya, would you please kick off our discussion with an overview of the risk faced by South Asians and why the OurHealth study matters?
Absolutely. Thank you so much, Dr. Begum and Ms. Khan, for inviting us here and for hosting this event. I just want to say to everybody listening right now, the South Asian Public Health Association is incredibly professional and incredibly diligent in their volunteer work and dedication to this cause. So I applaud all of you for attending, and I hope that you will continue to follow along with SAFA in their many endeavors to improve South Asian health in the United States. So with that, I'd like to talk to you a little bit about the OurHealth study. It's a study focused on lifestyle genomics and the elevated cardiometabolic disease risk in South Asians. I'd love to spend the majority of the time during this presentation in our moderated Q&A and our Q&A certainly from the audience. So if you'll permit us just a few minutes to get on the same page about some of the same vocabulary and kind of understand that we're all working from the same basis of facts, given that I'm sure that we have a wide experience and scientific knowledge here. So the first question is, you'll hear us use this term cardiometabolic disease quite a bit today. And what is cardiometabolic disease exactly? Many of us are familiar with cardiovascular disease, which of course are diseases of the heart and blood vessels. Oftentimes the blood vessels get short shrift here, but there are tens of thousands of miles of blood vessels in our body and only one heart. So it's important to think about both. So heart disease, of course, and cardiovascular disease refer to any diseases of the heart and circulation, but primarily the mode of death and disability that we think about with cardiovascular disease are diseases of the arteries and the artery walls, which sometimes we don't think about it that way. And that's a disease that requires two things to develop: excess cholesterol and inflammation. And so when the cholesterol is circulating in the body at abnormal levels, it starts to burrow into the arterial walls, causing narrowings in the arteries. When that blocks off an artery to the heart muscle itself, and the heart muscle can no longer get oxygen and nutrients, that's termed a heart attack. When that same process happens in the brain and an artery is blocked off to the brain, then that's termed a stroke. And the expansive world of cardiometabolic disease includes diseases of the kidney, the pancreas, insulin resistance, which ultimately leads to diabetes, and fatty accumulation in the liver as well. This spectrum of diseases, they all kind of work together and they're all very related, and they all lead to increased cardiovascular and cardiometabolic, or type 2 diabetes risk, which results in disability, disease, and yes, ultimately death. Next slide. What's quite interesting and unique about South Asians is that we keep demonstrating a similar finding across multiple continents, across many decades, and across different types of individuals who have different early life experiences and cultural practices. And that's that South Asians appear to have higher rates of cardiometabolic disease than other race groups. And it's interesting because this is particularly true among normal weight individuals. This is a graph coming from the Masala study, which is an epidemiologic study focusing on South Asian cardiovascular disease and cardiometabolic health within the US as compared to other ethnicities like white individuals, Chinese American individuals, African American, and Hispanic individuals. Now here we have the groups of individuals grouped into normal weight, overweight, and obese. And what we see is that in the normal weight category in particular, South Asians have a much higher rate of metabolic abnormalities than, for instance, their white counterparts. So over 40% of individuals in this cohort were normal weight and still had metabolic abnormalities, whereas their white counterparts, only around 20 or 22% of those individuals had metabolic abnormalities. This tells us that we can't just look at someone and know if they're metabolically healthy or unhealthy, and that's particularly true in South Asians. Next slide. And this is not just an issue of importance to South Asians alone. South Asians represent about 25% of the globe, so nearly 1 in 4 individuals are of South Asian descent. So this isn't simply an issue of South Asian health or others. It's an issue of global import. And very often when we study a group of people who has a high rate of disease, we're able to make discoveries that benefit the entire world. Speaking of a high rate of disease, although it has been observed in many, many different cohorts, even in the healthiest cohorts, when we study them, we find at least a 2-fold increased risk of heart attack in South Asians, heart attack and stroke, compared to Europeans. In one study that we did, we observed double the risk of heart disease in South Asians and Europeans in a large study of over 500,000 individuals. Go to the next slide. Now, when we go to the doctor, it's common practice for our doctor to think about what sort of preventive medications, how can we, or do you qualify for, and how can I keep you healthy? So what your doctor may do is they may enter your numbers, your age, your sex, your smoking status, your diabetes history, your high blood pressure, or rather your blood pressure, systolic and diastolic, and your cholesterol levels into a calculator that has been trained on tens of thousands of individuals to then try to predict your future cardiovascular disease risk. Now that may work very well if you are the typical patient on whom these risk calculators were trained. The one that's most commonly used in the United States, for instance, is called the pooled cohorts equation, and it includes exactly those risk factors: age, sex, blood pressure, cholesterol, diabetes, smoking history, and whether or not you're on medications to treat cholesterol and blood pressure. Those are what we call traditional, very well-known risk factors for cardiovascular disease. What we've discovered over the years is that there are groups of people who tend to be at higher risk than the risk calculator really thinks that they might be. And these are people who have what we call emerging risk factors, new risk factors that are beginning to develop a lot of data behind them, and yet we're not using them yet in clinical practice. Some of these risk factors might be biological conditions or traits, like having hypertensive disorders of pregnancy, gestational diabetes, eclampsia or preeclampsia, having premature menopause, having chronic kidney disease, abdominal adiposity, or that fat around the belly button that we know is the most dangerous type of extra fat to carry. It might be people who have a strong family history of disease, or it might be those who have subclinically elevated LDL levels, cholesterol levels, that don't quite meet the criteria for cholesterol treatment by primary care guidelines, but it's dangerous nonetheless. We can talk more about that later. Unique among these emerging risk factors, or these risk-enhancing factors, as they're termed by the American Heart Association, is South Asian ancestry. It's the most recent one to be added, and it's the one that we know the least about. And what's fascinating about this group is that this is the only historical, not exactly biological trait or condition that's been added to the risk-enhancing factors. This speaks to the fact that if we had a way to unpack this a little bit more, maybe we would know that not all South Asians are increased risk, or some South Asians have even more increased risk, and we'd be able to get more granular with that information. Next slide. Really, there are two major theories that have been proposed to explain these differences. One is that South Asians are uniformly sedentary. It's not part of our culture to exercise or to take care of our bodies, that we eat way too many pakoras, or we eat too many samosas and jalebi, or in my part of India, rasgulla, and that all of this is easily explainable as lifestyle and behavioral habits. The other sort of school of thought is that actually maybe there's something more here. We're seeing increasingly South Asians who are living very Western lifestyles, restore lifestyles from the country that they are living in, and yet they still have high rates of cardiovascular disease. So can it be all lifestyle? So there's the group that says that this may be genetic. Maybe it's something in our genes, or I've even heard theories that maybe this is due to serial famines in South Asia and that's epigenetic regulation. The reality is that maybe there's contributors from many of these areas, but being a data-driven person, I'd like to see the evidence, and I'd like to see the data to really understand which one of these is true and to what extent are they true. So that's where I'd like to pass it off to my colleague, Dr. Patel, who will tell us a little bit about how we begin to delve into the nature versus nurture question in this realm.
Thank you, Dr. Bhattacharya, for the introduction. A lot of the studies that Dr. Bhattacharya mentioned that found that South Asians are at increased risk of heart disease have occurred over the past 3 decades and all over the world. They've been fairly small in size and have had different risk factors that they looked at in conjunction with different outcomes. So what we wanted to know is, in today's world, in a modern healthcare system where people have equal access to different medications for prevention, like statins and blood pressure control, do we still see the same level of increased risk in South Asians or not? Or was it just a historical trend that has since fixed itself? So in order to do this, we examined over 500,000 people in the UK Biobank, which is a large national cohort that was designed in the United Kingdom that collected not only survey data, but also linked to electronic medical records, and also collected samples for genetic testing and other blood work. In this 500,000 people, we took out people who had prior events of heart attack or stroke at the time of enrollment in the study, and ended up with about 8,000 people of South Asian ancestry, about 450,000 people of European ancestry without heart attack or stroke at enrollment. These individuals were then followed for about 11 years and monitored to see if any of them developed a heart attack or stroke in that follow-up period. In the 450,000 Europeans and about 8,000 South Asians, at the time of using the data from the time of enrollment, we actually calculated what their aggregate clinical risk would be to develop a heart attack. So this is going back to that calculator that Dr. Bhattacharya talked about, that when you go to see your doctor, they plug in all these values to give you a risk, and that risk determines if they're going to prescribe you a statin or not to help prevent heart disease. And so here what I'm showing is the distributions of all those scores calculated for all those individuals, with red showing South Asians and blue showing Europeans. And the point of this is to show that the overall distribution of scores in both populations is overlapping, as in they're basically the same. So at the population level, South Asians and Europeans have similarly calculated elevated risk of cardiovascular disease using traditional risk factors. But that's the expected or the theoretical risk. What do we actually see in the follow-up period? So over 12 years of follow-up, here I'm plotting the cumulative incidence of heart attack or stroke along the y-axis. So, and blue designates European individuals and red designates South Asian individuals. So for 12 years of follow-up, you can see that South Asians were having nearly twice as many heart attacks and stroke compared to their European counterparts, despite having similarly expected risk based on these traditionally available risk calculators. So in essence, these traditional risk calculators just don't work in our population. We tried to get a better understanding of why they didn't work. And instead of having an aggregate risk that we looked at, we actually looked at each of the different possible risk factors alone and tried to account for them mathematically. So what I'm showing you here is the risk of heart attacks in South Asians relative to Europeans. So here the number is 2. And here the only things we account for in our model are age, sex, and what part of the country they lived in. So this is fairly standard. Now, as you can imagine, South Asians may have more diabetes or more high blood pressure. There may be a different diet. So we can sequentially actually account for each of these factors using math and see if we can make this, explain a lot of this difference. So if we account for different blood pressure control levels and different medication levels in the two populations, the estimate goes from about 2-fold increased risk to about 1.95. So it's a little less of a disparity if you account for high blood pressure. If you account for diabetes and kidney disease, so that's what GFR, glomerular filtration rate, is a measure of, that actually explains quite a bit of that disparity, suggesting that there's a lot of genetically driven diabetes or kidney disease in South Asians that's explaining a lot of that cardiovascular disease risk. But we didn't stop there. We also looked at a lot of those emerging risk factors, including chronic inflammatory diseases, female reproductive factors like gestational diabetes, different kinds of obesity and fat measures. So whether that's belly fat or BMI, we accounted for all of those. We also looked at traditional cholesterol and lipid panels, as well as a lipoprotein A, which has been implicated in South Asian heart health, and then C-reactive protein, which is a marker of overall inflammation. And we also looked at family history of disease, smoking, diet, healthy diet or not, activity level and how much time they spend sitting down, stressors, and then socioeconomic factors. And after accounting for all of these very comprehensive variables that we know are related to heart disease, and we account for them in a model, South Asians were still at about 1.5-fold increased risk of heart attacks and stroke compared to Europeans. So there's still a 50% unexplained risk, even though we use everything we have in our armamentarium to try to explain the risk. So what could be the reason for that? One is there's something that we haven't discovered, so some sort of biomarker or other variable that's unaccounted for, or there could be some genetic driver that's not being accounted for here. So how can we use genetics to better understand or help predict CAD risk or coronary artery disease risk? So I'm just going to give you a bit of a snapshot, a very 10,000-foot view of how this works. The human genome is comprised of essentially DNA. So DNA is the way that we encode information in our cells that help develop and maintain all living organisms. So humans have about 3 billion base pairs that make up their genome. So 3 billion base pairs of DNA. A portion of this makes up about 21,000 genes, which then produce proteins that work together to do all the functions of the body. 99.9% of our genome, so all of our DNA between humans, is the same. So it's identical amongst all of us. But that 0.1% of the genome is actually different, and that's what makes each of us different from each other. And so we refer to that as variation. And so a single base pair being different or altered is called a variant. That's the word I'll use to talk about changes in the genome. And so what we want to know is, what is a single variant or a single change in the human genetic code? How does that associate with cardiovascular disease as for starters? And so we do large studies called genome-wide association studies, where we say for a given variant, is it found more in people with a disease, or is it found more in people without a disease? And so if it's found more in people with disease or cases, that's referred to as a risk variant. So we repeat this process for all 3 billion base pairs to get an idea of how each place in the genome associates or doesn't associate with a disease. In our case, it's heart disease. So then here, work with me with the schema where each of these columns represents one person. And instead of 3 billion base pairs, I'm only giving you 6 base pairs. And so if we talk about that one variant that was associated with cases or a high-risk variant, we're going to color that red. And so this person has 6 risk variants, so 6 sites in their genome where they have a high-risk variant, whereas this person has no risk variants. If we add them all together, that gives us an overall genetic score of what their risk would be. We call this a polygenic risk score. And if you do this for a whole large population cohort, so thousands and thousands of people, and plot the distribution, we'll see something called a normal distribution, which is this sort of a curve. And people who have disease, so those in red, will have slightly higher polygenic risk scores, whereas those who don't have disease will have a lower polygenic risk score. So we did this in the UK Biobank. the same cohort where he looked at the South Asians versus Europeans. And this is a demonstration of the polygenic risk score at work for cardiovascular disease. So if you look at the people with the lowest polygenic risk score, so these people over here, that's the analogous to this area, and you added up how many, find the average amount of cardiovascular disease in those people, only 0.6% in the bottom percentile of the polygenic risk score had cardiovascular disease. Whereas if you were in the highest genetic risk category at the top percentile of the polygenic risk score, there's about a 16% average CAD prevalence in that group. And so here, genetics can be used on top of traditional risk factors to help prevent, to help diagnose or predict cardiovascular disease risk. But the problem here with South Asians is that majority of the data that's been used to make these sorts of scores comes from European data sets. And therefore, this sort of score doesn't work well in South Asian groups. In fact, even though South Asians make up a quarter of the world population, they only make up 1.3% of all genetic study participants. And so as a result, we are stuck with using DNA data from all these other ancestries, which work to some degree, but it can still be inaccurate in terms of predicting risk in our group, and raises the question of how can we improve upon this? And the short answer is we need larger and more inclusive data sets with South Asians that have not only clinical data, but also genetic data to do these sorts of analyses.
Thank you very much, Dr. Bhattacharya and Doctors Bhattacharya and Patel. That was very informative and eye-opening. I am generally concerned about my health in the future. But let's dive into our discussion. So this question is for Dr. Sengupta. So what is the OurHealth study and why is it important? And how is the study different from all of the other amazing studies that have already been done or are currently being done among South Asians?
Thank you for the question, Dr. Begum. That's the reason why we are here to, first of all, talk about the OurHealth study. So great segue into the panel discussion. So the OurHealth study is a nonprofit research initiative. It was founded by cardiologists and geneticists who were based out of Broad Institute of MIT and Harvard and the Massachusetts General Hospital and Harvard Medical School here in the greater Boston area. But now we've brought on key collaborators from Yale and Stanford. The study aims to discover underlying genetic factors for cardiovascular disease risk in South Asians. But what's really great about this study is participants will drive forward the research. And they're going to do that by contributing towards our health study, by filling out surveys, providing their clinical information, providing lifestyle information, and electronic health records, and also saliva samples. And Dr. Begum asked the question around what, besides this, what makes this study unique? There have been various studies, as Dr. Bhattacharya and Dr. Patel presented, that have looked at some really critical aspects of South Asian cardiovascular health. But what our health study is doing, its uniqueness is it's really bringing like all these data sets together, like co-localizing data sets. So what it's going to be able to achieve is getting individuals' electronic health records, genomic data, lifestyle data, clinical data, all together in one place, so that that would unlock the clues of the underlying genetics, or what is the root cause of cardiovascular disease. So that's kind of the summary of why our health study is important. But I think what we are really excited about is it's a community-based study. It's individuals are invited to participate in this study from all over the United States. And it's participants who will really drive the research forward. And that's why we are here out in the community talking to our fellow South Asians to discuss this work.
Thank you very much, Dr. Sengupta. Now, I do have a follow-up question. So what does participation in the OurHealth study entail? What would it look like? And who would your ideal participant for the study be?
Great. Dr. Patel, would you mind bringing up the slides again? We have screenshots from the website, which I'd like to walk through. And this is very much based on my recent experience of registering for the study myself. So this is the website. If you type ourhealthstudy.org, you will be brought to this website. And there are multiple places which actually takes you to try to register for the study. In the top right, you see the registration. or you see become a participant with all our collaborators listed under that. Next. About Dr. Begum's question related to who can join this study. If you are someone who's living in the United States, you're over 18 years old, you're comfortable filling out surveys in English, and you're of South Asian ancestry. And by South Asian ancestry, we follow the definition stated by the American Heart Association. So those individuals who have ancestry associated with one of these countries, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. Next. So I want to walk you through a little bit about what the experience of participating in OurHealth could look like. Step one, the places on the website that we showed here that you register, you do that, you click on that, and there'll be some basic questions around eligibility and to create your account. Step two will have you kind of consent to the form, and then step three, surveys, and step four is provide your mailing address for saliva sample donation. But the step 1, 2, 3, just since I did this myself recently, the next slide. I just wanted to show you that it's pretty simple. Step 1 is just study eligibility. It asks you these 4 questions. If you qualify, if you've answered these 4 questions based on what is the requirement, you then get moved to the next step. Next. And that's pretty much where it'll ask you to verify your email. Like the data security is really high for OurHealth. So, and it definitely does that at every step along your experience. So it'll ask you to enter the email, and it will send you a verification code in your email. Next. And once you enter the verification code, it'll have like a confirmation for you. Next. And then it asks you to create an account. So this is a step that you pay attention to. You have your email, you create your OurHealth study account with a password. Do not forget the password, remember it, and then you have created your OurHealth study account. The next slide. So once you've done that, that's where you really enter the dashboard, where you have a consent form, you have other surveys. But before even you get to surveys, you have to read and evaluate the consent form that you are agreeing to participate in this study. Next. So the consent, like this is some, I would encourage you to spend a few minutes, read what kind of consent you're giving to scientists and physicians to work with your data. And it also explains like how this is, what exactly will be done with the data and results from the saliva samples or the other surveys that you will fill out, how that will be used. So you give your consent, and then next slide, that pretty much then unlocks the survey part. So this is the part which I think I'd like to advise that based on my recent experience that you take time to sit down and fill out. But you can always like come back to it as far like, remember your login, take time to fill this out. I did it at one go, but to do this at one go, you kind of need all the information in one place. That is, it asks you about your, cardiometabolic medical history, your family's medical history, your lifestyle, prescription drugs that you take. So pretty much all of that. So any homework tips that I can give is make sure you have a list of all your prescription medications and your medical history, like just general awareness of that, because there will be specific questions. If we highly encourage that you include your family's basic medical history, and those were questions. There'll be questions about your parents' health and your grandparents and siblings. If you're aware of that information, make sure you have those notes when you sit down to fill out these surveys. And so once you've done the surveys, you'll also there'll be a place to enter your address, and a saliva kit will be mailed to you to donate your saliva and mail it back. So that's kind of the experience of, encouraging participants to take part in advanced cardiovascular disease research through this community-driven research effort. Next slide. Since I brought up the topic of community-based research, I think there's one other thing is it's not just about, as you saw through the presentations of Dr. Bhattacharya and Dr. Patel, that, it's not just about the genetics, it's also about lifestyle interventions. And both of them, cardiologists being here, can talk more about that. But I think another goal of the OurHealth study is to also really educate the community around what are some best practices associated with lifestyle. And so there's a whole resource page that has been built on the website under education, as you see the screenshot here. And I encourage you to delve into these resources. And the OurHealth team is working very closely with our collaborators. Some are on the West Coast, our Nourish team in Stanford, and the South Asian Health Center in El Camino. And they're developing amazing resources which are culturally, tailored. That is culturally tailored to the South Asian community, that not only we can absorb that information, but we take it out to our own families, we take it out to our own communities and kind of share this out. So there's going to be a kind of like mass education effort that is also an underlying goal of the OurHealth study. And then final slide. These are 3 things that I thought of sharing with everyone. Of course, our website, ourhealthstudy.org. If you've missed any information or want to connect with the team again, ourhealthstudy.org. And just follow OurHealth Study on X, Instagram, and Facebook, and just kind of also helps you reshare the content or reshare the call to action around sharing about this study and creating awareness about this study with your community, since we're looking for participation from all around the country. Thank you.
Thank you very much, Dr. Sengupta. That was very wholesome. It was a very wholesome explanation of the study. Now I'd like to move on to some other questions, and these are generally for the entire panel, but for some of them I might ask someone specifically. So what role does genetic play in determining increased risk of heart disease in South Asians?
Yeah, so I can take a stab at that. As of now, we have very limited genetic data to answer that question. And so that's part of the onus for this study. Just to give some context, that polygenic score that I presented and the genome-wide association study data that went into it, it was about 1.2 million people, most of which were European, and there's only 20,000 South Asians that were part of that. And the largest genome-wide association study that's been done in South Asia is about 20,000 people. And that may sound like a big number, but when you're looking at the minute changes that we're looking for that are associated with each of these variants, that's actually almost like a null study, because there's no way we're going to find a significant result with that few samples. And so, yes, we have as of now, we have not found any South Asian specific kind of risk variants or things that are different from the general population, but mainly because we haven't had the number of people to answer that question correctly. But regardless, we can still use genetics, like I demonstrated with the polygenic risk score, and to help predict risk. But one aspect that that has been proven to be useful is in pharmacogenomics. So one study that was recently published looked at genetic variants in a gene that controls Plavix metabolism. So Plavix is a drug that people get. It's a blood thinner type drug that people take after having a heart attack, and it helps keeps the stent open after the stent is placed, and you're supposed to take it for a year. And one of the complications that people who have a stent placed have after a heart attack is that that stent can form a blood clot inside, because either they stopped taking that medication or it wasn't working. And so we know that in some people, they just don't metabolize the drug well enough to make it at the active blood level for it to work. And there was a study that was done in the London area in the Bangladeshi population that found that almost half of the population had moderate to poor metabolism that led to higher complication rates after placing a stent. And alarmingly, there was 12% that were actually almost had no metabolism of this drug, so it wasn't even active after they're taking it. And not only was this drug inactive, they were actually having about triple the rate of these sorts of post-MI complications as everybody else in the study. So pharmacogenomics, which looks at how we metabolize drugs and which drugs work for us, that's one field where genetics is already being used. And this is a use case where we've seen a disparity upfront with the little data that we have. But if we amplify our data sets larger and larger, I'm sure we can answer or tackle these other bigger questions.
Yeah, and if I could tack on to that, Dr. Patel's point, like South Asians have typically taken part in clinical trials less than 1% of participants. And so, I don't know, many of you may have the same experience as I do, that family members or friends tell you that, oh, this drug doesn't work for me, or that drug makes me feel bad. And if we don't participate in research, we actually, I tend to reassure them and just tell them, hey, listen, actually, that's probably not true. This is what the trial showed. But if we don't, if we don't study them, do we really know that to be certain? And this study that Dr. Patel just referenced, it was eye-opening, because Plavix has been around since the mid-90s. And we've been using it's the most prescribed drug post-stent. And 57% of the individuals were poor intermediate metabolizers in that study. So for us to learn this 15 years later is shocking, actually. So it speaks not just to, hey, listen, we have to discover something new, but it also speaks to an equity issue that the things that we already know, we have to learn more about in South Asians.
Thank you very much. Now, I do want to ask, if I was participating in the OurHealth study, what would I get out of it? And also, is there a follow-up participation required, or is this a one-time thing?
Yeah, I'm really glad you asked that. I see a lot of questions in the chat around sort of this issue. So I'd love to address it. Right now, I'll say this, that we take your privacy very, very seriously. So we try our very hardest, and we do this in our data security, that we separate identifiable information from the analyses that we run. This is important to maintain your privacy, to not identify any one person, and to prevent against data leaks. We are not a for-profit research entity that is seeking to give back blood reports or sell any data or send anything to anybody else. So our primary goal in the analyses is discovery. So that's the number one thing. Now, similar types of genetic biobanks have taken a line that says basically, we don't want to share back experimental results with individuals. We want to make sure that what we share back with you is clinically actionable, relevant, and vetted by national societies. And it's been demonstrated to be the correct thing for clinical care. Only in certain situations do most biobanks that study genetics, if they discover a new variant that might be potentially lethal, that you could find out about no other way, would they break the confidentiality, shatter the glass, and then go ahead and reach out to you and say, hey, listen, there's a problem, we need to talk. Having said that, we are one of the, we're one of the centers that are developing. Dr. Patel is a world leader in developing these polygenic risk scores, and we do believe that there's a potential role for this in the future in clinical care. And so we are working very hard to develop clinically actionable reports and validate those and make sure that those are clinically sound before we talk about sort of returning those results to individuals, though that would absolutely be a goal of ours in the future. Right now, the direct benefit that you get from participating in OurHealth is really it's a community service. It's a service to our community, to our future generations. And I always say this because I think of us as just the sharp end of the spear. You guys are the driving force behind this project. And this project should and will only go as far as our community wants it to go. So if these are questions that we want answered, if these are important issues to us, then we should drive that forward.
Thank you. That definitely makes sense. Now, I do have another question before I move on to the audience. So many of our parents and grandparents live to be very healthy up until their old age. And is it really important for us to do anything different than what they did?
Maybe I'll point that to Dr. Sengupta up front.
It's a tricky question because, there's so much of, I would say, ancestral knowledge and colloquial knowledge and cultural knowledge that we have to navigate when it comes to practices of our families, like parents, grandparents. And then when we try to bring in changes that may be more relevant in our culture and our natural environment. So going back to your question, I think it also boils down to an individual choice. So whether we want to make any changes, it's completely a choice. But I will actually go back to something Dr. Bhattacharya just said. Is it really just for our generation, but it's also for the next generation? I think we have seen increased risk of, the reason we are here is because there's such an increased risk of cardiovascular disease and diabetes in our community. And what is the future that we want to give to the next generation? And are there, maybe if our parents or grandparents haven't followed certain practices and maybe it's hard for them to change their lifestyle, could we adopt certain things so that those around us, maybe it's our siblings, friends, community members, our nieces, nephews, children, they are observing it. So I think cultural shift in interventions like this, or raising our hand to participate in a project like this, or actually making changes in lifestyle could be something which can be a departure, slight departure. But at the same time, I think one of the things we're striving to do is keep it still culturally relevant. It's not about, we're not saying giving up your, the food that you like, but is there a different way of balancing that food? And there are organizations that are doing incredible work who are partnering with us to get that kind of information out to the South Asian community, which will be easier to even take that information to our parents and grandparents and bring it to them that, hey, this is just that one tweak that we can do to the way we are eating our food, or the extra steps we need to take for our, daily walk. So hopefully it's going to be like a large community effort, and not just for those of us who live in the US, but, it's for the South Asian diaspora. We have families and friends and communities spread all over the world and back in home countries. So hopefully it'll trickle further.
Thank you very much. So the OurHealth study will have a wide-reaching impact if we could get it done. Now, I do have a question. Does the OurHealth study distinguish in data between people who are fully South Asian descent and of mixed people? And have other studies looked at this? And did they find that the risk was same, or were there differences in their risks?
I can speak to the OurHealth study side, and I think maybe Dr. Patel can speak to some of the other questions. So, race and ethnicity is a very tricky topic in today's day and age. I think that what we do know is that currently the best way we have identifying this group of people who seem to be at high risk is their ancestry, but we don't really believe that their ancestry or where they came from is the thing that's causing their risk, right? We suspect that there are things in their genetics and things in their lifestyle and habits that cause them to have certain risk factor profiles. And so ultimately, it's not like right now, for data collection purposes, it makes a lot of sense for us to say, hey, South Asians, like, we know you're at high risk. Let's talk about that. But when we're actually doing analyses or we're thinking about risk, we're trying to think about what is the biological process here, and who the person is or what they look like or where they came from matters very little. To that piece, I will say that, mixed race individuals are incredibly valuable, incredibly important in this. They are sort of the future of our global community, first off. But secondly, they demonstrate these dose effects of certain genes that maybe are more common in one group and less common in another. And they hold the potential to unlock a lot of answers. So there's no blocking of anybody. This is all by self-identified race and ethnicity. If you feel like you're South Asian or you're of South Asian ancestry, you are more than welcome to participate, and we really welcome your participation and engagement. And that's all I'll say from the OurHealth side. I'll hand it off to Dr. Patel.
Yeah, so in the biobank study that I presented, we did look at mixed individuals, so people who had a parent who was either European and the other parent was South Asian. That was the largest group, but there was very few of them, I think on the order of 500 to 800. And we saw that they actually had very similar risks to the European counterparts. And again, it's hard to tease out why, whether their lifestyle was largely similar to the native UK individuals at that point. We have done some studies looking at immigration patterns. So how recently did they immigrate to the UK, and how that risk kind of translated. And what we found was that regardless of whatever generation, whether that's, recently immigrated like 10 years ago or 50 years ago, all three groups were at high risk, but those that were considered admixed were essentially normalized risk. So it's hard to tease apart if it's a acculturation / complete assimilation culturally versus some sort of genetic mixture. But again, we'd love to, investigate that further, and we need way more than 500 people to do that.
Thank you so very much. As we're coming to the close, I'm going to ask one last question before handing it off to Samira. So can you share some actionable recommendations for what someone can do given that South Asians have a higher risk of CVD?
That was on lifestyle interventions. Yeah, so I think that it's such an important question. So I think that what we should probably look at is, if you guys are, I know you're at your computers right now, but if you Google the American Heart Association's Life's Essential 8, there's a whole host of resources that are really, really targeted towards this exact question. There are 8 essential factors that we think about, and we say that, if you optimize for these 8 factors, your risk of cardiovascular disease drops tremendously. And I'll say that there's work that has been done by our group, our principal investigators and others, that has demonstrated that even those, and actually especially those at the highest genetic risk of disease, benefit the most from improving these lifestyle factors. So these include a healthy diet. These include getting adequate physical activity and lessening your sedentary time, which are 2 different things, but we can talk about that maybe at another date. Controlling your blood pressure, maintaining a healthy weight, controlling your blood sugar, controlling your cholesterol, getting enough sleep, and reducing your stress. And these things are the elements of a healthy lifestyle. And I will say that, incidentally, for South Asians in particular, I think that the exercise training is a really important part. Across many cohorts, we've seen that the reported, and this is even self-report, right? So I see several comments about the concern about self-report, but this is self-reported physical activity is actually really, really low in South Asians, and so getting moving is a really, really critical piece of that.
Thank you very much, Dr. Bhattacharya. Now I have one final question, actually, before I hand it off, and this is for Dr. Sengupta. Do the participants get any of the reports back? The saliva sample that they submit, do they get any reports back on what was found?
It will. I'm going to ask actually Dr. Bhattacharya to continue with the response. But one thing I did want to say that, and this tying back to another question I saw in the chat, was how are you going to share your findings? The OurHealth team, when you are just registering for the study, you are in a part of a specific database, your email is, where they will regularly, on a regular basis, reach out and share with you the progress of the study. So any new publication comes out, any new findings, you will be part of what is like the group of participants in a newsletter. And if there are relevant information, that will be shared out to you as part of that group. But I will let Dr. Bhattacharya handle the question about individual reporting.
Yeah. I know that this is an area where people are really anxious to get some information back, and that's absolutely our goal. We know that there are ways that people have done this responsibly and well, and for us, we want to be exceptionally well trusted and putting out information that is really the most accurate, verified, and clinically actionable that we can. To that end, it may take us a little longer than other groups. We're also a small effort that we're trying to build actively. And so my hope is that I'll be able to come back with you and share with you great news about the way that we're able to share this back, and we feel confident about those results. Given that, other, larger organizations that have larger participant basis. So for instance, I see that the All of Us study was mentioned in the chat, South Asians have not been studied as much. And so we want to be able to produce a product that is of high quality and is able to be shared in the appropriate ways. And so I hope that this is forthcoming in terms of genetic sharing, but at the very minimum, we will be sharing any scientific information that we are able to derive from the study with our participants first, and later in more detailed scientific publications. And so you will find it in infographic form, in short digestible form. You'll also find it in the form of scientific publications. This is exactly what we want to do, and we want to share that with you because we're doing it for all of you. So yeah, that's what I'm saying.
Thank you very much, Dr. Sengupta, Bhattacharya, and Patel for sharing your time and expertise with us today. I'm seeing a lot of positive energy and positive vibes about the OurHealth study. We are at the end of our discussion today, sadly. Samira, can you please take it over and provide some closing remarks?
Sure, absolutely. This was great, very informative, and I saw a lot of questions come in, and so we tried to address as many of them as we could. However, what we'll do is, I think we've collected some of the questions on our end for SAFA. We can share it with the OurHealth team, put together maybe an FAQ and email it out when we send out the reporting, as well as some other materials. We've compiled some infographics and some ways that you can advocate for cardiovascular health in South Asians as well. And so that'll all be packaged together. You'll get the actual documents once you complete a follow-up survey, just a way to ensure that we get a lot of feedback. And so that will all come out next week when we send out the email with the recording. Before we end, I did want to just talk a little bit more about what's upcoming for SAFA. So I'm going to just quickly share my screen. So we are going to be releasing the third episode of our podcast series next week with Dr. Arnav Mukherjee at Cal State East Bay. He has been a previous SAFA president and has been an immense, support for SAFA and has been a great mentor to many South Asian youth as well. So that will be released next week, and you'll get an email if you've been subscribed to us. In addition, in April, we are going to be hosting a workshop that discusses advocating against caste-based discrimination, especially because it is going to be Dalit History Month. And so that is upcoming in April. In May, SAFA is planning to have a mental health awareness virtual event. The formatting of the event is still being planned out, but just stay tuned for announcements regarding that. And then late in October at the American Public Health Association conference, we are having an annual in-person event. We call it the Giant Chat event. It's usually a mixture of networking and panel discussions and roundtables. And so we have that every year at the American Public Health Association conference. This year it's going to be taking place in Minneapolis. And so I believe the dates are I think the last week of October, right before Halloween. So if you're in the area, feel free to attend. The event is free to attend in person. You don't need to be registered for the conference to be able to attend the actual event, since it is going to be in the evening. And again, once these dates are finalized, we will be circulating it via social media and our newsletter. Secondly, if you're interested in getting involved with SAFA, I hope that we've enticed you enough to consider taking a more active role. You can sign up to be a committee member. So again, we've had those 5 committees. Committee members essentially work with the co-chairs and our board of directors to put a lot of the programming out. And so you can bring your ideas, sign up for projects, really take control of some of the projects that you want us to see being done. And so you can sign up for that in 2 ways. You can either scan this QR code, or if one of the SAFA board members can also put the link in the chat. That will take you to a Google form to sign up, and then we'll review and get back to you for what committees we think you'll be a good fit for. You can also go to our website, to our contact page, and sign up here. We have the link to the interest form located here as well. Second, if you are, working as part of an organization and are interested in partnering with us, in our newsletter that we sent out today, we did include a blurb about how to partner with us. So Amish Doshi, who's on the call, our partnership coordinator, he's the person to reach out to. You can email us at partnership@safa.org. Maybe Amish, if you can put that in the chat as well. If you are as part of an organization, or if you're just interested in sponsoring us or partnering with us, putting together events like this, feel free to reach out, and we can have a discussion about what that looks like. Lastly, to stay connected with all the work that we're doing, you can scan the QR code to sign up for our newsletter, or if a SAFA board member can put the link in the chat, that would be great. You can go to our website. We are on Twitter, Facebook, LinkedIn, Instagram, and YouTube, and also Spotify. If you Google our podcast series name, you'll be able to find us on Spotify. The URL is a little too long to put here. But please follow us on social media, stay engaged with the work that we're doing. We really want to expand this community and have as many people involved as possible to help improve the health and well-being of South Asians across the US. With that, thank you all for coming, and we hope that you attend our future events. Thank you.
Thank you very much, everybody.